Welcome to the deep dive. Today we're plunging into a truly remarkable area of reconstructive surgery. It tackles what's maybe the most profound challenge, rebuilding facial structures, like ears, eyes, the nose, when they're just not there, maybe from birth or later.
Yeah, it's incredibly complex.
And it's not just about filling a space, it's about getting results that work and look natural aesthetically, which is, well, it's unbelievably hard when you don't have much soft tissue or cartilage or bone to start with.
Exactly. And for a long time, traditional methods really struggled there. They faced some pretty severe limitations.
Surgeons were kind of stuck with the tissue they had.
Pretty much, yeah. They were constrained by what they could manipulate.
But then something revolutionary happened. This came out of that pioneering work by Bronmark and others back in the late 60s, early 70s.
Right.
They brought in this idea of using external titanium cranial implants for prosthetic reconstruction. It sounds almost like science fiction, doesn't it? Titanium bolted, well, anchored right into the bone.
Yeah, anchored. It really was groundbreaking stuff.
To hold like a new ear or nose.
And, when this concept first came out, there were understandable worries, concerns from doctors about, well, how stable would it be long-term? What about infections?
Sure. Makes sense. It was totally new.
Very novel, yeah. But then more work in the late 70s and early 80s by researchers like Kjellstrom, Albrechtsen, Bronmark again, Lindstrom. That really shifted the view.
Okay.
Their research showed that these applications outside the mouth, not just for faces, but also for bone-anchored hearing aids, were actually a really reliable technique. Solid, durable.
And they've certainly proven to be reliable since then. So for our deep dive today, we're going to explore the two main ways people approach these complex reconstructions. We'll get into the incredible precision needed with these titanium implants and really how this whole technology has just completely transformed lives.
Absolutely.
Okay, so rebuilding a missing part of the face. You basically have two main paths, right?
That's right. Two main avenues.
Let's start with the one using those clever titanium implants we just talked about.
Okay, so that's what we call implant-retained prosthetic reconstruction. And what's really interesting here is the general agreement, the consensus, that this way often gives a cosmetically better result.
Better than using the patient's own tissue?
Often, yes.
Yeah.
Especially for really complex shapes, like an ear or a nose.
Yeah.
I mean, think about it trying to perfectly recreate all the delicate curves of an ear or the exact angles of a nose, just using living tissue. It's nearly impossible to get it perfect with traditional surgery alone.
Right. I can imagine the detail is incredible. So if the goal is that really lifelike look, what makes these prostheses work so well?
Well, a few things. The implant-retained ones, they can offer amazing symmetry, matching the other side. The color match can be incredibly accurate, and the tiny anatomical details can be captured.
Wow.
Plus, a huge advantage is how securely they attach. Patients aren't messing around with sticky adhesives or double-sided tape or even trying to balance things on their glasses anymore.
Oh, I didn't even think about using glasses.
Yeah, people did. But those older methods, they had real downsides. Skin discoloration, allergic reactions, or just failing. The prosthesis falling off at the worst time.
Yeah, not ideal.
Definitely not. So this secure, stable attachment, it really boosts a patient's quality of life, better self-image, they can be more active, and just managing the prosthesis day to day is so much simpler.
Okay.
And another key thing, because it is a prosthesis, it doesn't distort the natural tissues around it.
That's important for checking for cancer recurrence, I suppose.
Exactly. It allows for much better tumor surveillance, especially if the defect came from cancer treatment. And interestingly, it might even be a good option for patients who've had radiation, even though radiation can make that initial bone integration a bit trickier.
That sounds incredibly positive. It gives people not just a new look, but real freedom. Are there downsides? Any significant drawbacks to this implant approach?
There are a few things to keep in mind, yeah. These prostheses, they do need maintenance. They're made of tough stuff, but, normal wear and tear, color changes over time.
Yeah.
They'll need replacing every few years.
Okay, that's practical.
And there is still a small chance of it getting dislodged, which you can imagine might happen at less than ideal moments, social events, sports.
Right.
And while most patients really thrive with these, for a very small number, there might be some adverse psychological effects from wearing an external device. It's just something to be aware of.
Okay, that makes sense. Now, what's really interesting, too, is the other way, using the patient's own tissue. What's the basic idea there?
Right, so that's autogenous reconstruction. Autogenous just means using the patient's own living tissue.
Got it.
And the core advantages here are pretty significant. You're building something stable, long-term, with living tissue that has its own blood supply.
So it's alive, essentially.
Exactly. That means it can fight off infection naturally, it can heal itself, and in younger patients, it might even grow along with them.
Oh, wow.
It's often really good for fixing partial deformities, where it can blend in really well. And practically speaking, you avoid the ongoing costs and maintenance of an external prosthesis.
So it's natural, it heals, maybe even grows. That sounds almost perfect. What's the catch? What's the trade-off?
The main trade-off generally is the final aesthetic result, the look. Especially for something really intricate like an ear, the reconstructed part is just less likely to be an exact mirror image of the other side compared to what you can get with a custom-made prosthesis.
So maybe not quite as lifelike.
Often, yes. The aesthetic outcome can sometimes be, well, less than totally satisfying for both the surgeon and the patient. And these autogenous procedures, they're also really demanding surgery-wise.
How so?
They usually need multiple stages, multiple operations, often involving things like stretching the skin for tissue expansion or needing several grafts, moving tissue around from nearby areas.
Okay, so it's a bigger surgical undertaking.
Definitely. And that multi-stage approach also means more surgical risks. Things like problems with the blood supply to the new tissue, potential nerve damage, hair loss at the donor site, infection, plus just more discomfort overall, both at the reconstruction site and where the tissue was taken from.
And I bet it takes a lot longer for the patient, too, going through all those stages.
Oh, for sure.
Yeah.
A standard 4-stage autogenous reconstruction. That can easily take about 9 months to finish.
9 months?
Yeah, and maybe add another 3 months if you need tissue expansion beforehand. Now, compare that to the implant-retained prosthetic route. That can often be done in maybe 4 to 5 months if the patient hasn't had radiation.
Wow, that's a huge difference in time.
It's a substantial time commitment, the autogenous way.
So when you're weighing up these two paths, it sounds like precision is absolutely critical, especially if you are going the implant route, getting those posts in just the right spot.
Oh, absolutely critical. You know, the single most important technical thing for success with these titanium implants is getting their position spot on.
Right.
And that's never just the surgeon working alone. It absolutely requires close teamwork, close consultation between the surgeon and the person making the prosthesis, the maxillofacial anaplastologist or prosthetist.
From the very beginning.
Right, from the early planning stages. Because if you put those implants in the wrong place, even slightly off, well, it can make the whole plan impossible. The prosthesis just won't fit or look right.
And I guess before they even get to the operating room, there's a lot of careful planning, like detailed scans and maybe even guides.
Yes, exactly. That pre-placement evaluation is key. Detailed imaging, like CT scans, gives a really clear map of the bone quality and quantity. And yes, often a prefabricated surgical template, like a custom guide, is used during surgery to make sure the placement is precise.
Okay. And do different areas of the face need different approaches for placing these implants?
They do. Each site has its own unique challenges and considerations. Take the temporal bone, for instance, where implants usually go for ear prosthesis.
Right.
Surgeons have to think carefully about the skin flaps, and they need to meticulously thin out the tissue right around where the implant comes through the skin. This stops the skin from moving around too much later on. But they also have to be careful to keep a good blood supply to that flap.
Delicate balance.
Very. And there are specific measurements like how far from the ear canal, how far apart the implants should be, that are really critical for success and for the final look. They even have specially designed implants just for this area. The good news is the complication rate for temporal implants is actually extremely low.
That's good to hear. What about around the eye? Orbital implants?
For orbital implants, they're usually placed radially, sort of like spokes on a wheel, within the bony rim of the eye socket. Ideally, the outer lateral rim is best because the bone is thicker there.
Okay.
The inner part of the orbit, near the nose, that's generally trickier, thinner bone, more complex structures nearby.
Yeah.
And here's a really crucial point. The implants have to be placed just inside the orbit, slightly behind the rim.
Why behind the rim?
To allow enough space, enough thickness, for the artificial eye and surrounding prostheses to sit naturally and effectively camouflage the implants in the transition line. You don't want the fixtures showing.
Makes sense. And the nose, I imagine that's got to be tricky, given how delicate it is.
The nasal region is definitely considered technically challenging. Often the bone quality isn't great there, and the soft tissue can be very thin and fragile, especially if the patient has had radiation therapy.
Right, radiation again.
Yeah. Implants are often placed in this sort of triangular pattern. Usually they go through the floor of the nose near where certain teeth would be, but surgeons have to be incredibly careful to avoid hitting tooth roots or important nerves like the nasopalatine canal.
Wow, it sounds like navigating a minefield sometimes. There's so much detailed 3D planning involved. I'm guessing technology like advanced software must play a huge part now.
Oh, absolutely. It's a game changer. There's advanced software like Maxillofacial concept software that's incredibly helpful. It takes the standard 2D medical scale images, DICOM files, and builds a full 3D model from them.
So you can see everything in 3D on the computer.
Exactly. Surgeons and prosthodontists can see the remaining bone, the soft tissues, all with amazing clarity. They can then virtually place the implants on the screen.
Like a dress rehearsal.
Precisely. They can check the exact angle, the trajectory, choose the right connecting pieces, the abutments, and tweak the plan over and over until they get the most seamless transition, the best aesthetic emergence profile, where the implant meets the skin.
And that virtual plan then guides the real surgery.
Yes, it provides a precise blueprint for the operating room.
So bringing it all together, it really hammers home those key things for success. Collaborating early with cancer surgeons if needed, making sure there's enough good bone, thinking about the soft tissue thickness, and that meticulous planning with the prosthetics expert for that perfect, seamless look. It really is a team effort.
A symphony of specialists, absolutely.
So once these amazing implants are successfully placed, what's the next step for the patient? And the big question, how long do these things actually last?
All right. So after the implants are in, there's a healing phase. This is for osseointegration. That's the crucial process where the bone literally grows onto and fuses with the titanium implant surface, creates that super strong bond.
How long does that take?
Typically between 3 to 6 months, surgeons might use a traditional two-stage approach where they place the implant, let it heal under the skin, then do a second small surgery to expose it, or sometimes a one-stage protocol where the healing cap is placed right away.
Okay, 3 to 6 months for the bone to bond. Now, people listening might be wondering, what about problems like infections around these parts that stick through the skin?
That's a fair question. Soft tissue reactions, maybe some minor irritation or redness around the percutaneous part of the bit coming through the skin can happen. Reported rates vary quite a bit in the literature, anywhere from 3% up to maybe 60% experiencing some kind of minor reaction, but it's often just mild redness or irritation.
Okay, so mostly minor stuff.
Often, yes. A more significant soft tissue infection, usually caused by common skin bacteria like staph, is the most common complication we see. And this is key with really good patient hygiene, keeping the area clean. And meticulous surgical technique in the first place, these issues can be kept to a minimum.
Right, so hygiene is super important for the patient afterwards.
Crucial.
So assuming they integrate well and hygiene is good, how successful are these cranial implants long term? Does it vary depending on where they are on the face?
Yes, the success rates do vary a bit by location. It reflects the different challenges of each spot. The most predictable site, the one with the highest success rates, is the temporal bone.
For the ears?
Exactly. Success rates there are typically really high, like 92% to 98%.
Wow, that's impressive.
It is. Orbital implantation for the eye area also does very well, usually in the 91% to 96% success range.
It's still very high.
Very good rates. The nasal region, as we discussed, is the trickiest. Bone availability, managing that thin, soft tissue. It's just more challenging.
Yeah.
So success rates there are a bit lower, maybe ranging from about 70% up to 80%.
Still pretty good considering the difficulties.
Still a very viable option, absolutely.
Okay, this brings up something we touched on earlier, radiation. What happens if a patient has had radiation therapy to the area? How much does that affect the implant success?
Ah, yes, the radiation factor. It's a big one because placing implants into radiated bone is quite common, especially after cancer treatment.
Right.
Radiation definitely impacts success rates. Studies show increased failure rates, sometimes significantly higher, maybe 17% to 42% higher failure rates compared to non-radiated bone.
Why is that? What does radiation do?
Well, it basically damages the small blood vessels and causes the soft tissues to become fibrotic, kind of stiff and scarred. This reduces the oxygen supply, which is vital for that osseointegration process, for the bone healing onto the implant.
So it makes it harder for the bone to bond.
Much harder. And the orbit, the eye socket area, seems to be especially difficult in patients who've had radiation. Success rates there can sometimes drop to around 50% to 66%.
Ooh, that's a big drop.
It is. But while radiation clearly makes osseointegration tougher, it's worth noting the risk of a really severe complication called osteoradionecrosis, where the bone itself dies due to radiation, is actually pretty low with these craniofacial implants.
Okay, that's somewhat reassuring. Is there anything that can help improve the odds in radiated patients?
Yes, there is something quite remarkable. Hyperbaric oxygen therapy, or HBO.
Like going in a special oxygen chamber.
Exactly, breathing pure oxygen under pressure. Studies have shown this can dramatically improve implant integration rates in radiated bone. There was one study, quite notably, that observed no implants lost in irradiated patients who received HBO therapy beforehand.
No implants lost. That's incredible.
It really highlights the potential benefit. It seems to help improve that oxygen supply to the tissues.
Wow. Okay, so we've covered the surgery, the implants, the healing, but there's this whole other dimension to it. This is where maybe science really meets art. We're talking about anaplastology, right?
That's exactly right. Anaplastology. It's a fascinating field.
What exactly is it?
Well, fundamentally, it's the art and science of applying prosthetic materials like silicone to reconstruct a part of the body that's missing or disfigured or wasn't fully formed.
So making the artificial part?
Making the artificial part, yes. But it's more than just making a part. The anaplastologist is the person tasked with that incredible challenge of restoring the delicate beauty, the individuality of features like the human ear or nose or eye area, making it look completely natural and seamless.
It sounds like incredible artistry is involved.
It truly is. A blend of technical skill and artistic talent.
And I gather their work starts way before any surgery even happens. Those pre-op appointments seem really important.
Absolutely critical. Meeting the anaplastologist beforehand is key. They can show the patient examples, manage expectations, maybe show before and after photos. And crucially, if a part is going to be surgically removed, they'll often take impressions before the surgery.
To capture the original shape.
Exactly. To capture that natural anatomy, it provides an invaluable reference, something familiar for the patient, which helps enormously in creating a prosthesis they connect with and feel is truly theirs.
Okay, so when it comes to the actual prosthesis, how does it attach? We mentioned implants, but are there other ways?
Yes, broadly speaking, there are two main attachment methods. You've got adhesive-retained prostheses. These don't use implants at all.
Just stuck on.
Essentially, yes. Using special medical adhesives. The advantage is they can be made relatively quickly, and obviously no surgery is needed for implants.
But what are the downsides?
Well, they can be a bit cumbersome to manage day to day, especially maybe for older patients or those with limited dexterity. Getting them positioned exactly right every time can be tricky. And their effectiveness, how well they stick, can be affected by things like skin oils, sweat, soft tissue movement underneath, even just humidity in the air.
Right, like we talked about earlier, the risk of them coming loose.
Precisely.
Oh,
Which leads us to the other main type, implant-retained prostheses.
using those titanium anchors.
Exactly. And these provide that secure, consistent attachment we discussed. This really helps alleviate the psychological worry about dislodgement. Patients feel much more confident.
And it always goes back in the same spot, I guess.
Exactly. Perfect positioning every time. Plus, they generally tend to last longer because they aren't being pulled off and reapplied constantly with adhesive.
Okay, so within the implant retained ones, are there different ways they connect the implants?
Yes, the two main systems are either a bar and clip arrangement, where a small custom bar connects the implants and the prosthesis clips onto it, or magnetic attachment.
Magnets. That sounds easier.
It often is, yeah. Magnetic attachment is frequently preferred because it can be easier to clean around the implants, and it generally requires less manual dexterity from the patient. The magnetic force itself can actually help sort of guide the prosthesis into the correct position.
Like it snaps into place.
Kind of, yeah. And there have been advances here, too. There's a recently developed O-ring magnet system that provides even stronger retention than conventional magnets.
Wow, the technology keeps improving. Now, the actual creation of the prosthesis itself, that sounds like where the real craftsmanship comes in. How does that process work?
It's a meticulous process, definitely.
Yeah.
It often starts with really sophisticated design, using that 3D technology we mentioned, scanning, computer-aided design, maybe even milling machines.
To get the shape perfect.
Exactly. For instance, scanning the patient's other existing ear to create a perfect mirror image for the prosthetic side. And if there's some natural cartilage remaining near the defect, the anaplastologist might skillfully use that, perhaps sculpting it into a neotragus, a new little flap of tissue which can really help hide the front edge of an ear prosthesis beautifully.
Clever.
Very. And those surgical templates we talked about earlier, they're designed in collaboration with the anaplastologist to make sure the implants are placed not just for stability, but also in positions and at angles that will allow for easy cleaning around them once the prosthesis is in place.
Practical considerations built right in. Okay, so once the design is set.
Then comes the impression stage,
Mhm.
taking a really accurate mold of the defect area and the surrounding tissues, usually using precise materials like polyvinyl siloxane. And they need to capture how the tissues move, like if it's for an ear, how does the area change when the patient opens and closes their jaw?
Dynamic movement.
Right. The resulting cast, the model made from that impression, that becomes the canvas. This is where the sculpting happens, often using wax first. And this is a stage where patient feedback is really encouraged. They're involved in refining the shape.
So they get input into how it looks.
Absolutely. Then comes the challenge of making the edges disappear, disguising the margins.
How do they do that?
It's really skillful. They use existing natural features, skin wrinkles, and maybe old scar lines, patient's hairline, to hide the transition from skin to prosthesis. For an eye prosthesis, the patient's own eyeglasses can provide fantastic camouflage for the edges. For a nose prosthesis, it requires incredibly thin, delicate tapering of the silicone margin so they just blend away.
Wow. And then the color. Getting the skin tone just right must be incredibly difficult.
It is probably one of the most complex parts. Creating realistic skin colors in silicone isn't just about matching one shade. It's about mimicking how real human skin interacts with light, how it absorbs some light, transmits some light.
So it needs depth.
Exactly. You have to consider opacity, translucency, the actual hue or color, the value, how light or dark, the chroma, the intensity. And you have to account for something called metamerism.
Metamerism? What's that?
That's the phenomenon where a color match looks perfect under one type of lighting, say indoors under fluorescent light, but looks slightly off outdoors in natural daylight.
Oh, right. I've seen that with clothes sometimes.
Exactly. So the anaplassologist has to be incredibly skilled at anticipating that and creating a color that looks natural under various lighting conditions. They do this by intrinsically mixing multiple shades of silicone, then adding layers of surface glazes, maybe tiny painted-on shadows or highlights, freckles, tiny veins, all custom blended for that individual patient.
It sounds like painting a masterpiece, but in silicone.
It really is a form of artistry, layer upon layer of detail to achieve that lifelike realism.
So what does this all mean for, someone listening or for the patients who go through this? What's the ultimate impact?
The ultimate impact, the goal, is that the final result should be essentially undetected at a normal conversational distance. You wouldn't even notice it.
Wow.
And that transforms a patient's self-esteem. It changes how they present themselves to the world. It frees them from constantly feeling like their condition is the first thing people see. It allows them to just move through social situations, through life, with a profound sense of restored confidence and normalcy.
What an incredible journey we've covered today. From those initial really tough challenges of missing facial structures all the way to these innovative solutions, it's clear that this cranial implant retained prosthetic reconstruction has been, well, an astonishing success. And often it's really the only viable path for patients with these very complex defects, whether they're burn survivors, people born with congenital conditions, or even individuals where attempts at using their own tissue just haven't worked out.
It truly is. And it just underscores, again, how vital that meticulous planning is, getting the implant position just right, and then the need for consistent long-term care and maintenance from the patient. These aren't just procedures. They really are life-altering transformations.
Yeah.
Blending that cutting-edge science and technology with a deeply human, artistic touch.
What's so fascinating, I think, is seeing how this mix the surgical precision, the advanced tech, like 3D planning, and that incredible artistic skill. It isn't just rebuilding a piece of anatomy. It feels like it's fundamentally restoring a person's identity, their confidence, especially when they're facing such incredibly difficult circumstances.
Oh,
it really makes you think. As this technology keeps getting better, as our ability to recreate what's missing becomes even more seamless, how might that change your ideas about what looks normal or even natural in the future?
That's a profound question to ponder, isn't it? How these advancements continue to shape our perceptions.